Welcome back to this podcast exploring the science and innovation behind Eustachian tube dysfunction. I'm your host, Dr. Bahar Ashour. Today, we're joined by Dr. Dennis Poe, professor of otolaryngology at Boston Children's Hospital and Harvard Medical School, and a pioneer in Eustachian tube research and interventions. His work has shaped our understanding of Patulous Eustachian tube dysfunction and opened new frontiers in drug delivery and surgical approaches. In this episode, we'll cover what makes Patulous Eustachian tube dysfunction unique and challenging, current and emerging strategies for managing Patulous Eustachian tube dysfunction, novel drug delivery systems and surgical innovations for Eustachian tube dysfunction in general, and we'll wrap up with a few practical clinical pearls you can apply in your own clinical practice. Dr. Poe, thank you for joining us. It's an honor to have you.
My goodness, it's an honor to be here, and I greatly appreciate the opportunity.
So let's get started with the basics. For many clinicians, Patulous Eustachian tube dysfunction can be elusive. How do you define it, and what makes it so clinically distinct from obstructive Eustachian tube dysfunction?
Well, that's a great question. So we actually think of Eustachian tube or Eustachian tube dysfunction now as a whole spectrum, ranging from obstructive through lesser degrees of obstructive, maybe just sometimes, like when you fly, and then progressing to being partially open to being fully open. If it's fully open, that's a patulous, from the word patent, Patulous Eustachian tube. And some patients can actually go back and forth on that spectrum, depending on whether they have inflammatory diseases like allergic rhinitis. So the main distinction is now we've got an stuck open valve, and the patients complain bitterly about the symptoms of hearing their voice and breathing echoing, because the closed valve protects us from that kind of reflux of sounds and even nasopharyngeal material.
It seems kind of like a paradox, this Patulous Eustachian tube. I mean, patients like having their head in a head-down position. So many of them who do yoga or exercises like that, they enjoy that sensation. They feel comfort when their head is dependent. They also feel comfort on descent in an airplane when everybody else is struggling to pop their ears. So do you find when you take a history, are these the kind of things you ask about for a patient with Patulous Eustachian tube dysfunction?
Well, so most of these patients don't come in complaining specifically necessarily about the symptoms of patulous. The main symptoms that help us identify patulous, they would be autophony. So you're hearing your own voice and your own breathing abnormally loudly. It's actually very similar to putting a stethoscope in your ears and you're holding the diaphragm up to your mouth and you're talking and breathing. It's extremely loud and disturbing. Voice, breathing. Many of them get pulsatile tinnitus, and but the patients often don't complain about that. They may often say, my ear is blocked and my hearing is muffled. Even though we test their hearing and it's normal, my hearing is muffled. And they use language that can mislead us. They'll say, my blocked ear, I put my head down and my ear unblocks. What's really happening is they've got a stuck open valve, a patulous valve. And when they put their head down, the venous congestion closes the Eustachian tube. It's the exact physiological opposite of what the patients describe to us. So it's very misleading. And the quick, if someone comes in, I've got ear fullness, my ear's blocked, muffled hearing, it's going to make the doctors immediately think about obstructive dysfunction. So we have to always have a suspicion that there could be patulous and ask about it. And it turns out it's very common, much more common than we used to think, because in misdiagnosing it for these reasons.
So do you think there's a psychological factor involved that some patients are more bothered by these symptoms than others and will tend to complain more? Is it related to anxiety and psychological factors and possibly associated temporomandibular disorders?
Right on target. So it absolutely is. And there's a couple of different reasons for it. There is the group in whom the condition happens, and it's so disturbing to them, it induces anxiety. And we see it especially in people who are professional voice users. It's really interfering, singers, lawyers, teachers, etc., college professors. It can be really disturbing for their profession, public speakers. And then you've got another group in whom their anxiety, they're tense. Their muscles are tense. They clench. They have temporomandibular disorder, which is tension in the muscles of mastication. It's usually not a TMJ, temporomandibular joint dysfunction. It's most commonly TMD, the muscles of mastication, temporomandibular disorder. And so these anxious patients get TMD, they tighten their muscles, and the medial pterygoid muscle is actually an auxiliary dilator of the Eustachian tube. It can pull the valve open if it's tight enough. So they cause the symptoms, it adds to their anxiety, and now they're stuck in a vicious cycle.
So I guess it's really important in the history to kind of probe for these things and also take like a psychiatric history as well and check the temporomandibular. What other conditions should be excluded as well in the differential diagnosis?
Well, so the differential diagnosis of oral fullness, we have to sort out between obstructive and patulous dysfunction. The majority of time, the patulous patients are going to have a normal tympanic membrane, but if they're sniffing hard to control their symptoms, sniffing, then negative pressure closes the valve temporarily, gives them some transient relief until they swallow or yawn again. So they do it all day long. We've been calling these habitual sniffers. It's not habitual. They're controlling patulous symptoms. They're patulous. But they can cause enough negative pressure to cause tympanic membrane retraction, medullary effusion, and for all the world, it looks like an obstructive dysfunction. So we have to be really careful. Why are you doing all this sniffing? And the patient will mislead us. They'll say it's unblocking my ear. Well, it's really closing their valve. So we have to rule that out. We have to then think about other causes for ear fullness, oral fullness. Temporomandibular disorder is number one.
Yeah.
And then there's some lesser common inner ear conditions, otic
Superior semicircular canal dehiscence, maybe. Yeah.
Exactly. And even otologic migraine. I just want to mention, why are we talking about patulous? And the reason is there's much more awareness of its existence now that we've been making advances in Eustachian tube surgery. There's a lot more discrimination in making the diagnosis. People are realizing that we've been misdiagnosing a lot of patulous as obstructive dysfunction.
So I guess after a history, the next thing would be to actually take a good look into the nasopharynx and try to see the Eustachian tube itself. So here's an image. I think this is one of your images from a previous study, and it shows the typical findings of a patulous Eustachian tube. Could you just guide us through what we're looking for in the nasopharynx?
So what you have here is an angled endoscopic view looking at a left Eustachian tube. And we talk about the valve having two walls, a cartilaginous wall, which is an extension of the torus tubarius as it progresses proximally toward the isthmus. And then you have the membranous wall. That's where the tensor belli palatini muscle and just deep to that is the pterygoid muscles. So the most common defect we see with patulous is what you see on that white arrow on the left-hand picture. But a defect at that location is also very common, even in normal patients. So just seeing a defect at the orifice doesn't mean it's going all the way through the length of the cartilaginous portion of the Eustachian tube, which is about 25, 27 millimeters. So we have the patients do swallows to open the valve, and then they do yawns and vocalize ah for sustained maximal dilation. And that's what you see in the right-hand picture. Now the patients open the valve as much as they can, and we see that defect there at the top, at the roof, the 12 o'clock position, it is traversing about as deep as we can see into the valve. Now again, we're not seeing all the way full length to the isthmus. So this is not diagnostic, but it correlates with your history and your physical, the other physical exam that you're going to do of your ear. The hallmark of patulous, the final diagnosis would be if you actually see excursions of the tympanic membrane with breathing, especially nasal breathing will augment it. Even ipsilateral nasal breathing, opposite nostril closed, will augment it. And we're not talking about forceful breathing, just deep breathing and looking for excursions of the tympanic membrane.
So you're saying that it's not just enough to look at the opening of the Eustachian tube, that you actually need to do a dynamic endoscopy of the Eustachian tube while the patient is vocalizing and deep breathing, and to see deeper into the tube itself to get a good idea what's going on.
Absolutely. There's been lots of literature in the past of looking at static views of the Eustachian tube, and it did not correlate with clinical findings. What's changed that is the dynamic endoscopy. It's a valve. You want to see how well it opens and how well it closes, like looking at the vocal cords. You want to see the actual function.
So I'm gonna stop sharing this image here for a second. Would you like to show the video that you have of that dynamic endoscopy? I think that would be very useful.
So I'm going to share here. All right. And you can see that.
Yes. Yeah.
So an important point to begin with is frequently to get an adequate view of the valve of the Eustachian tube, you need an angled endoscopy. So here we have a 0 degree. Can you see my cursor?
Yes, I can.
We have a 0 degree view, and this is commonly what you see is we see the cartilaginous wall. This is a right Eustachian tube, adenoid here, but we don't see much of the membranous wall. So here with a 45 degree view, we see a beautiful view of the whole orifice and of the valve. 30 degree is usually adequate. 45 is even more reliably adequate. Now, most of the time I don't use a rigid scope. So I typically do what you're going to see here. So I've done an endoscopy. This is a flexible scope. It's in the left nostril. Now I've parked it in the nasopharynx. I'm turning the scope 90 degrees so I can flex it back and forth across the vomer. So we're now looking at the right Eustachian tube, and I can turn the camera on this setup. This happens to be a patulous Eustachian tube. This is the lateral cartilaginous lamina. I have the patient say ka, 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 just to flex the levator muscle here in the floor. They then do a swallow for a normal dilatory effort, and then the yawn, looking down the length of the lumen with a maximal dilatory effort, or an ah. Some patients get a better view with an ah versus a yawn. So here we go over to the left side. Now, the view is partially obstructed by this mucus. So let's not let that stop us. This is one of the things I like about the flexible scope. I can go right through that. So now we got a nice view down the lumen. Ka, ka, ka to flex the levator. Swallow to contract the levator and tensor. And then a yawn. And here you can see that defect, that superior defect's going all the way as far as we can see. So this is the view you want for both your obstructive dysfunction patients and your patulous patients. How well does that valve open? How well does it close? And what pathology do you see in the lumen? It's a dynamic exam.
That's great. Yeah, that was very clear. Thank you for that. Before we move on to diagnostic imaging, I wanted to ask you, you mentioned allergic rhinitis. Now, in general, one thinks of allergic rhinitis contributing to obstructive Eustachian tube dysfunction. How does it also contribute to patulous Eustachian tube dysfunction?
Well, that's a great question, and it's been a big surprise for us. We, in our study of demographics of patients with patulous Eustachian tube, allergic rhinitis came up to be about 50%. It was actually 49% of our series that allergic rhinitis as a comorbidity, followed by weight gain, which was about a third, followed closely by reflux, and then followed by temporomandibular disorder anxiety. So it's turning out that chronic inflammatory conditions, especially allergic disease, can cause burnout of the overstimulated mucosa. And we know this histologically. This has been shown in the nose and sinuses, patches of burned out atrophic mucosa and submucosa, nose and sinuses. We see it endoscopically in the valves of the Eustachian tube. Even though they may have robust inflammation in the nose, nasopharynx, even the orifice of the Eustachian tube, and yet when you do that dynamic exam and you look at the membranous wall in the valve, you can see that there's actually atrophy there. You might see Ostman's fat. You'll clearly see that there's a defect. So they probably start out with obstructive dysfunction, and over time they become patulous. But the patient just keeps telling us they have a blocked ear all the time.
Yeah.
So we have to ask about specific symptoms, and that's autophony. Are they frequently sniffing, which is really common? These are your poppers and clickers, also TMD. Obstructive dysfunction patients usually don't have popping and clicking. So autophony, frequent sniffing, the clicking and the popping, and we're highly suspicious if they've had a chronic allergic history.
Yeah. So this burnout would be after a number of years of allergy and allergy medication, like taking intranasal steroids for many years. So converting what was initially a hypertrophic mucosa into an atrophic mucosa.
Yeah, and I want to be clear, I don't think it's a side effect of the medication, because we can see robust inflammation in the nose, nasopharynx, even orifice of the Eustachian tube, but it happens to target the valve for reasons we don't know.
Yeah, so it's more of a natural history of the disease than a side effect.
Right.
I'm going to share
It's very slight. Well, sorry, just to make a comment, it turns out it's very common in pediatrics. So you want to suspect this in the kids who have started to need multiple tympanostomy tubes.
Yeah.
Children who don't outgrow obstructive dysfunction needing tubes after age 6 frequently have allergic disease as a root cause. And a number of these kids who are needing multiple tubes turn out to have turned into patulous. And we miss it because they sniff, they come in with an effusion or retracted drum, they get a tube, they stop sniffing, the tube comes out, they sniff, and the effusion comes back. They get referred for possible balloon dilation because they've now needed multiple tubes. But on history, it turns out they're patulous.
Yeah, the balloon dilation would make things worse in these cases.
It would.
Do you think maybe that following an adenoidectomy, it might unmask a child who had a patulous Eustachian tube and it shows up after the adenoid has been removed?
Well, that's a great question. Most people doing an adenoidectomy are going to focus on the central 2/3 and spare the lateral portion. Although increasingly with now endoscopic techniques, we do go for the lateral portion because that's where it impacts on the torus tubarius of the Eustachian tube. If there's significant adenoid hypertrophy and it's bumping that up against hypertrophied tubal tonsil tissue on the medial torus tubarius, that can actually functionally block the Eustachian tube when it's supposed to open. It causes what we call anterior thrusting, where the torus tubarius is being pushed anteriorly and blocking the lumen when they swallow. So I haven't really seen where lateral adenoidectomy and trimming of tubal tonsil tissue has unmasked a patulous patient. But if a patient already has some tendency to patulous, they've had it, for instance, intermittently, but most of the time they have obstructive dysfunction, typical allergy patient, and they've got robust adenoid hypertrophy, I do consider leaving a little bit of that tubal tonsil and lateral adenoid for just that reason. I don't want to make them patulous.
Yeah. So I'm going to move on to the next image, which is an image of a CT scan. Let me see if I can share that with you. So after the endoscopy, would you routinely order a CT scan for these patients, or when would you think that's a good idea?
I don't routinely order a CT up front if they've just got straightforward Eustachian tube symptoms. Now, adults shouldn't be getting obstructive Eustachian tube problems, so it may be indicated, look for sinus disease or other things. But if it's just a patulous complaint, I usually don't obtain a CT up front. If they're failing medical conservative management and we're starting to think about surgery, then everyone gets a CT. Or if there's a question of diagnosis, we may want to get a CT.
So if the diagnosis is not clear cut and you're starting to think of surgery, then a CT. What kind of CT do you usually order? Is it a cone beam or a regular CT?
My preferred CT is a cone beam because the patient is sitting up. As you mentioned, when they lie down, the venous congestion closes the Eustachian tube valve in most of these patients. So a supine CT can often miss the diagnosis. With a supine CT, you might see a little bit of length of air column in the Eustachian tube that could give you a hint of it, but you're not going to see the full length of the pathology unless they're sitting up. So I do prefer a cone beam. This is a multiplanar reconstruction, so that you can actually see an air column in bilateral patulous Eustachian tube. It's going all the way the full length of the cartilaginous Eustachian tube. So this is kind of a worst case scenario. But if they have a tendency to patulous, but they're not actively having the symptoms of the time, you might see a long length of air column, but not fully open. So that's what we look at. And that gives us some idea about the severity of the condition. And that also helps us in terms of medical management that you just addressed.
So are we actually seeing more cases of patulous Eustachian tube dysfunction, or are clinicians just more in tune or looking for it or more aware of the entity? Or is it an actual increase in numbers because of things like using GLP-1 agonists like, Ozempic and Mounjaro, and what they're talking about, the so-called Ozempic ear that we're hearing about nowadays?
Yes, well, so there are both factors going on, but there actually is an increased incidence that's been reported in a national database study that came out of South Korea. So it's a significant increase year by year in recent years. So the bariatric and GLP-1 agonists are likely having a significant effect. And there are a number of papers showing bariatric inducing patulous. Helge Sudhoff, who's one of our working group members, a real leader in this field, he's also reported the GLP-1 agonists causing patulous. That was a recent report.
And does it have something to do with the rate of weight loss, or is it a percentage of body weight that has to be lost for patulous to appear?
That's a great question. We don't have a definitive answer on that. It appears to have more to do with rate. It's the rapid, if you lose it excessively rapidly, that seems to induce the condition rather than just percentage of body weight. Some of these patients just lose 5 kilos and start getting patulous.
Yeah. Okay, so let's move on to management. Once you're pretty sure of the diagnosis of patulous Eustachian tube dysfunction, what is your stepwise approach to management? And in your opinion, what are the biggest gaps that we still have to fix in this condition?
So the first thing, when we've made the diagnosis, the next is to look for what's the underlying cause. And if it's allergic disease, which is the most common comorbidity, not necessarily causal, but we have that suspicion, we want to get the allergies under control. And that means shifting from the usual drying agents, antihistamines, nasal steroid sprays. We try to cut back or discontinue those and switch to environmental measures. Cromolyn sodium is a nose spray, which is not as much of a drying agent. Nasal saline irrigations, and are they a candidate for immunotherapy? So we do a lot of allergy testing and generic management if the allergy testing comes up negative. false negatives, as we know, are very common. So we're quite aggressive about looking for and treating allergy to get things under control from a long-term perspective. Weight loss, we don't tell patients to gain weight unless they're actually medically underweight. In general, gaining weight after the intentional weight loss has not, the weight goes elsewhere. That doesn't make the symptoms go away in the majority of cases. TMD is a big one. Reflux. Everybody knows how to treat that, but TMD is a real big one. You got to get those muscles to relax. We send the patients off either to their dentist or to an oral medicine practitioner, dentists who are trained in non-surgical TMD management. That's often an interdisciplinary approach, physical therapy and all sorts of other measures. So we try to get to the bottom of it. And then what else can we do? A lot of these folks, their symptoms happen when they're dehydrated, particularly with exercise. So good hydration, we try to push like 2 liters of fluids a day. We minimize things that are going to dry you out over the counter, caffeine, other stimulants. And then we talk about topical nasal agents. So we can wet the Eustachian tube with topical saline drops. Sprays are not very effective. You want to use some drops. They'll get in deeper. Nasal saline irrigations are great, especially if you have allergies. And if wetting it isn't good enough, then we go to irritant drops. And we typically use hypertonic saline. They can buy that in the pharmacies, or they can mix it up at home. 4 teaspoons of table salt in a roughly 2 deciliter cup of water is close to hypertonic saline. Or we have to mix up lemon juice and water. They can
That must be very unpleasant in the Eustachian tube, getting lemon juice up your Eustachian tube.
So you dilute it with water. You could start with a preparation of half and half, which is fairly potent, and that's comparable to some compounds that you can buy over the counter for patulous relief. But if it's too irritating, you can always dilute it with more water. Yeah. So the irritant drops, what they're doing is they're stimulating mucosal swelling and more mucus. The idea is to try to stop the wind airflow through the Eustachian tube that's happening, because it dries out the mucosa.
Yeah.
And if we can try to stop the symptoms as much as possible, it gives the mucosa a chance to rehabilitate. Mm-hmm. And then we have to teach the patients how to put the drops in. Basically, you have to lie virtually supine, so nose is up in the air, and hang the head back about 15 to 30 degrees. Apply the drops to the ipsilateral nostril, turn toward that ear, ipsilateral ear, 45 degrees. So it looks like a hall pike position, but not quite as extreme a head hang.
Yeah. And the patient will feel the drops when they hit the Eustachian tube. They're going to feel a little pinch or a twinge, right?
Exactly. It radiates toward their ear.
Yeah.
So, because if they don't get that twinge, they missed, and they have to alter their position.
Yeah, yeah. Do you use like a special dropper or a long pipette or something to get those drops in there?
Yeah, these are all great questions. But yeah, we like these flexible plastic micro pipettes because they're a little longer, and so they'll get it into the nose a little deeper. Yeah. I think it helps the efficacy.
Yeah, great. So how long would you stick with the conservative measures before moving to the next step?
I tell the patients 6 weeks, 6, maybe 8 weeks. If they're getting benefit from these topical drops, and if they do it straight out for about 6 to 8 weeks, it can build up a lasting benefit. So that's what we're looking for.
Okay. And what would be the surgical options that you would discuss with your patients if the conservative measures don't work?
Well, so the first thing we look to see, are they a candidate for mass loading of the tympanic membrane? This is work by Manohar Bans. Basically, if you weight down the eardrum, it may help a lot of the patients with their patulous symptoms. the folks who have a predominant complaint of their breath autophony and breathing, moving their eardrum, they feel the breath and moving their eardrum, they are more likely to benefit from mass loading than the patients who complain more about voice autophony.
Yeah.
But it's worth a try. There's simple things you can do. A paper patch applied to the tympanic membrane. You could moisten some cigarette paper. You could put an adhesive steri-strip, adhesive tape. Manhar Bans originally talked about blue tack, putting a lump of it on the posterior TM. You want to apply these things to the posterior TM. That's where the excursions are greatest. Sometimes you can use a dab of ointment, a generous dab of ointment that you just squirt through a syringe and catheter.
Yeah. Do you think a tympanostomy tube is beneficial for patients with patulous Eustachian tube dysfunction?
So I would try the mass loading with these types of things first, because if you just go to a tube or grommet, a lot of the patients will hate it. They're already sensitized to abnormal hearing, and they are particularly sensitive to just the effects of the tube altering their resonance in their ear. So many patients will get a tube and come back a week later asking for you to take it out. So I would try the mass loading first. If they like it, they're much more likely to do well with the tube. So that's the progression. Are they good candidate for mass loading? If they like it, try. You could repeat it or try a tube. Now, if they're needing tube after tube, but the tubes work really well, a permanent way of mass loading would be a cartilage tympanoplasty, putting cartilage into the posterior TM.
Creating an artificial perforation and grafting it with cartilage.
Well, not even creating a perforation, just grafting cartilage to mass load it.
Yeah.
So most of the effect of the tube seems to be its mass
Weight.
rather than rather than the fact that there's a hole. Although some people actually do need the hole, but that's unusual.
Yeah. So if that doesn't work, what's the next step?
To be clear, the majority of our patients don't wind up getting a tube. We'll try the mass loading. It didn't work, so I'm not going to go to a tube.
Yeah.
At this point, I get the CT scan. If I haven't already done it, in the process of diagnosis. And what we're looking for on the CT is the severity of that air column, and is the internal carotid artery showing any dehiscence as it faces the Eustachian tube. If it's dehiscent, which is not common, if it's dehiscent, then I don't want to put any kind of hardware in the bony portion of the Eustachian tube where it's going to be adjacent to the carotid.
Yeah.
So the most common procedures that we often offer to patients are a shim, a plumber's shim to fix a leaky valve.
I think I have an image of that. Let me just share that on the screen and we can talk about it while we have the image.
So there is a commercial shim, or actually it's called the Kobayashi plug, that's available in Japan. I don't know of any other countries that have a commercial shim or plug. The idea of these is not to completely obstruct the Eustachian tube, in which case they would need long-term ventilation. And if you completely block a Eustachian tube completely, there's a relatively high incidence of mucoid effusions that, even though you put a tube or a grommet in the tympanic membrane, this mucus can be so thick it plugs the grommet, and they wind up going back to the otolaryngologist every 6 weeks to get suctioned out. So we try not to completely block the Eustachian tube. So it's a plumber's shim to try to make the valve competent without completely blocking it. Now, we don't have commercial shims here, so we improvise. We use angiocatheters. Most commonly, I use a 14 gauge. That's 2.1 millimeters outside diameter. About 8% of the time, I use a 16 gauge, which is 1.7 millimeters OD. So what you see here is a 16 gauge. and I cut it to length. It's going to go the full length of the Eustachian tube. The idea is it wedges into the isthmus, being passed transnasally. The isthmus is what's going to hold it. And this catheter, being flexible, is going to naturally lie in the concave defect that's usually in the membranous wall of the Eustachian tube. So, so we cut it to size. Most women are going to get a 36 to 38 millimeter length. Most men, 38 to 40 millimeters. So I aspirate molten bone wax to fill it, because you don't want a lumen on this. The lumen, first of all, could pass patulous symptoms. Second, it'll clog up with secretions and possibly cause infection. So we occlude the lumen with molten bone wax, the full length of the shim. Let it harden, which is about 30 seconds, and cut it to length based on their head size. Small heads get the smaller size. So typically, we're looking at 38 to 30, somewhere between 36 to 40 millimeters. You'll need some kind of curved instrument with a lumen to position it into the Eustachian tube, and you'll need some kind of a stylus to push it through. What you see here in that left image is actually a plunger designed. It's an introducer that we designed, and Karl Storz had them on the market for a while. They withdrew it due to lack of sales. If we knock on their door enough, maybe they'll revise it. This one is being passed through the mouth. It's being introduced to the orifice. You insert it just like you would a balloon dilation catheter. You line it up with the membranous wall, not the torus. The membranous wall takes you along the length of the Eustachian tube valve. And with a balloon, you stop at the isthmus. With this, you feel the isthmus and you keep going. So we push it through the isthmus, typically another 15 millimeters. So it should end up just short of showing up in the middle ear. And then we take an endoscope, 0-degree endoscope, look in the ear, make sure it doesn't appear in the ear. If it does, I'll pull it back about 2 millimeters. And the end result should look like what you see there on the right panel. It's sitting in place, it's not falling out, and it's inside the anterior pillar. It's not protruding more than maximum 5 millimeters.
And these shims would be permanent, or what? You just leave them in there for good?
So they can stay in indefinitely. I've had some of them in there 20 years. We don't take it out unless it's causing a problem, need for recurrent tubes, mucoid effusions because they're overly blocked, recurrent otitis media, acute otitis media because the shim's gotten a biofilm on it. So those would be reasons to remove it, or it's partially extruded and causing symptoms, it's poking the palate. Many of them extrude themselves, come out of the nose and mouth, or lodge in the nasal cavity, and you remove it in the office. I never heard of an aspiration case, never. I've had 2 people swallow it, harmlessly passed. So yes, they can stay in indefinitely, and remarkably, patients don't feel them.
I think it might be a good idea to have some sort of treated shims so they don't produce biofilms. Maybe some sort of layer that prevents microorganisms from sticking to them might be a good idea. But yeah.
So as you know, people have been working on that for tubes, grommets. The silver coated tubes, and people have looked at other things, but haven't solved that problem entirely.
Yeah.
It's a good thought. I'll mention injection of fillers. These are relatively commonly done.
Yeah.
Fillers could be, all sorts of things have been used for fillers, from gel foam saline to collagen to hyaluronic acid, fat, minced cartilage, calcium hydroxyapatite, and even many others. Basically, all of the things that have been injected into the larynx for restoring vocal cord, functional vocal cord function, all of those things have been tried on these Eustachian tubes. Most of them are absorbed and are not necessarily permanent. There are some permanent fillers that have been used off-label in Europe, of polymers, and the early results with those have looked favorable, but we don't have those in the States either. Fillers tend to work best on small defects, not large ones. And the hardest one to fix is that 12 o'clock roof defect that you showed that picture earlier. The mucosa is not very thick up there, and it's a little harder to get it to hold the fillers. So I find the fillers work best for small defects in the more central portion of that membranous Eustachian tube. So small defects in a favorable location, you might jump to a filler instead of a shim. Now,
What's the best material that you would recommend for a filler?
so of all the things that we have available, the calcium hydroxyapatite is the longest lasting. It's got about an 8-month duration. And as these microspheres of calcium HA are getting absorbed, you're supposed to grow in collagen scar to replace some of that volume. But it's quite variable how much collagen gets deposited by these patients. So there's a high rate of needing repeat injections in these patients. But if you can do it in the office, it's not necessarily a bad thing.
Yeah. I mean, with all of these procedures, it seems like you're trying to get into the Goldilocks zone. You don't want to over inject and you don't want to under inject. And it seems like sometimes you might have to stage these procedures over a number of times until you get it just right.
Exactly. Or the treatment turned out not to be adequate, and you've got to add to it. That's absolutely right.
There's another way to manage a patulous Eustachian tube by inserting cartilage around the valve.
Right. So if you've got a patient with a large defect and they've got a dehiscence of the internal carotid artery, what can we offer? This is one option. Also, if the shims are not working out, they keep falling out, you put a suture to it, it still won't hold long enough, or it keeps getting infected, or it's causing ear problems. This is our next go-to procedure. So what you're seeing here is a left Eustachian tube, panel A. I've got the endoscope in the nose. I'm introducing instruments through the mouth. And the reason I like doing them through the mouth is you've got more degrees of freedom. There's just more room to move your instruments. And I use a number of instruments that were originally designed by Karl Storz. They've been discontinued. These instruments are now available through, similar instruments are available through the Spiegel and Thies. So these are available. Okay, panel A, what you're seeing is a sickle knife making a vertical cut along the torus tubarius. Again, it's the left side. And so we're looking to do a submucoperitoneal flap. That's what you're seeing in panel B. So it's just like doing a septoplasty.
Yeah.
Get onto the cartilage. And my favorite instrument for developing that plane deeper is what you're seeing there is a wormhole frontal sinus suction dissector. And I've bent it so it can go through the mouth. And it will go all the way 20 millimeters. You see, I've scraped a little mark. You see the arrow, the white arrow there. That's a 20 millimeter mark. So many people, when they start working on the Eustachian tube, they focus on the orifice. The defect is actually much deeper in the valve. So you really have to get up pretty high, much higher than you would have expected. Remember, the length is 25, 27 millimeters. So I try to make this pocket 20 millimeters deep. You got to be very careful to hug that cartilage so you don't perforate the flap. Otherwise, the cartilage implants may just spill out into the lumen. And then what you see here are wedges of cartilage being stuffed into the defect. And keep in mind, it's going to be a kind of pyramidal shape as the Eustachian tube narrows superiorly. So that's why these are wedges. And I stuff as much as I can put in there and still be able to suture it shut, which is what you see in panel D. And there are suture techniques where, using these curved instruments, you can learn pretty quickly how to do that. It's not as technically challenging as you would think, but there are some important tricks to make it as simple as possible. We teach our residents to do it. They can all learn to do it with 1 or 2 cases.
Where are you harvesting the cartilage from?
Um, so in the past, I took it from the concha or from the septum. I try to stay away from the septum because it tends to bleed down over your staking tube. Uh, Most commonly now, I use off-label allograft cadaver cartilage. It's just right there on the shelf, and it really saves a lot of time using the allograft cartilage. Now,
Makes sense.
this looks great. The results up front are excellent. About half of the patients wind up getting some tiny opening and getting some symptoms a few months later. So I tell the patients up front, I've got a 50% rate of having to do a touch-up operation similarly on the membranous wall side. So the opposite side, opposite valve, I'll wind up putting cartilage on the opposite side in about half of these patients. Once they've had both sides done, the long-term success rate is really excellent. So half the patients may have to be ready that it might have to be a 2-stage deal.
Do any of these patients end up with a middle ear effusion, or because you're not actually obliterating the lumen, that doesn't happen?
Well, we're overcorrecting to begin with because you're going to lose roughly 40% of that implant volume, like you do with any graft.
Cartilage. Yeah.
You're going to lose volume. So we overcorrect it. So they're intentionally obstructed up front. They all get a tube. The question's going to be when that falls out, will they need more tubes? The majority don't, but some do. And some, frankly, become chronically obstructed and do need tubes repeatedly. So that's a known risk.
Yeah. I read something recently about a procedure called laser curvature inversion. Have you had any experience with that?
Yeah, that's Dr. Yanez in Mexico City. He's been doing those. I don't know if he's still doing those. I tried it a couple of times. I didn't find it that effective, but the idea was making some cross hatching, so basically horizontal cuts into the cartilage to weaken the cartilaginous wall, allowing it to uh, basically develop a convexity into the lumen of the Eustachian tube. But you got to go pretty far and deep with that. So I didn't find it as effective as I was hoping.
Yeah. Okay. Okay, that's great. So let's go to the next topic, which I'd like to talk to you about. So looking ahead, the future. What excites you most about emerging technologies for Eustachian tube interventions?
I love talking about the future.
Yeah.
Well, so what we've learned from a lot of these procedures, balloon dilations, patulous, we're altering the mucosa and the function with our surgery. We're having effects on the mucosa, medical effects on the mucosa. Um, so it's not just an anatomical change. And what this means, there's a big future for medical treatment for these conditions. So we need a lot of research on the basic science side for what medications would be most effective. And I'm thinking about slow release drug delivery to get these to work for us. What are we
Like
going
with
to?
stents or something, stents inside the Eustachian tube, slow releasing steroids, for example.
That would be one version, and there are a lot of people, a lot of patents already out there for drug-eluting stents. Um, but it's not just necessarily stents. What about just sprays or something that we would inject in the office with a deep catheter with mucoadherent um, compounds that are going to slow release? And what will they release? These could be surfactants, localized anti-inflammatory, mucosal modifying agents.
Biologics.
Exactly, biologics. And, maybe these are going to be nanoparticles that will make it mucoadhesive and slow release. So, we've seen nasal spray with surfactants that was designed to really get deep into toward the Eustachian tube. First clinical trial didn't work, but they're trying to set up to do another one. Another exciting possible application is topical chemical permeators or transmembranous drug delivery. So think of eardrops that will go through the tympanic membrane with a payload. And there are some of these already in existence in chinchilla models, chemical permeators or liposomes that will go through the tympanic membrane. Currently, they're depositing antibiotics and treating acute middle ear infection without a perforation. Now, these compounds getting into the middle ear, they're going to go down the Eustachian tube eventually. So we could put our slow release drugs into these compounds, and now you've got an eardrop that's treating the Eustachian tube. Or maybe some of these things could be delivered transnasally.
So I think we're like the exhalational delivery devices that use a patient's own exhalation to push the medication deep inside the nose.
Absolutely. All of these kinds of strategies to get the compounds back there, but to make them stick and then have these long-term effects. So stay tuned. Drug delivery, that's going to be an amazing future. Injectables, for the short term, we need some longer lasting fillers that are approved, and maybe we should be injecting some drugs. There might be some drugs that would stimulate mucosal thickening for the patulous patients. Keep in mind, if we're going to do some injections, these can't be particulates. We've had bad experience from particulate steroid injections into the turbinates where there was retinal vein occlusion and blindness. So if we're going to be injecting things, they've got to be either too big to get into a vessel or a solution that can't cause that problem.
Or too small, like nanoparticles. I'm not sure if nanoparticles could cause an obstruction. They're so small.
Agreed, as long as they're not going to clump. One of the things about nanoparticles is they can clump because of protein deposits, antibodies attacking these foreign materials. And so a lot of the nanoparticles get coated with polyethylene glycol, PEG, to prevent that kind of issue. But we'd have to be sure that these compounds are not going to clump in vivo.
How about emerging surgical techniques and maybe navigation, robotics? Do you see any benefit of these things in Eustachian tube dysfunction management?
Absolutely. So some of these things are already reality. There's a Korean balloon dilation device that it already has a navigation wire with it. So you know exactly where you are. But right now we're limited to operating on the cartilaginous Eustachian tube. And there are a number of things that we would want to do that we can't do with just a balloon. What about trying to get up into the bony Eustachian tube? So now there's advances where there's even smaller endoscopes that are going to get us up there better, with better resolution than we had in the past. And working channels so we can start delivering therapy to these sites of pathology that we couldn't reach before safely. I think there's going to be other devices for delivering energy or maybe injections into these deeper locations. So we'll be able to navigate and see more safely. We can work around the carotid where we couldn't safely do it before because we were working blindly. I think the future is very bright for these kinds of technologies. And some of these could be passed down through the ear at the time you're doing a tympanoplasty, cutting out the scar in the bony part of the Eustachian tube. We don't like to balloon in that area because of the carotid. Even if it's covered with bone, you might cause a crack. So yes, imaging, navigation, microinstrumentation, new energy devices, injectables, drugs, stents. Wow,
Super exciting. Super exciting.
you bet.
So I'm gonna wrap it up with some clinical pearls, just so our colleagues can integrate some of this stuff into their own practice. So I think it's really important to confirm patulous Eustachian tube dysfunction with dynamic endoscopy. Static exams can be misleading. Pearl number 2: start simple: hydration, topical therapies, mass loading before invasive steps. Pearl number 3: injection augmentation works best when targeted to the valve region and to avoid overcorrection. Pearl number 4: novel stents, drug-eluting devices may soon change our paradigm, so it's important to stay informed. And pearl number 5: always counsel patients on realistic expectations. Eustachian tube dysfunction management in general is often staged and iterative. Would you agree with those statements?
Absolutely. I think those are pearls of wisdom. And thank you for sharing them.
Thank you very much, Dr. Poe, for sharing your insights from clarifying patulous Eustachian tube dysfunction to exploring future innovations in drug delivery and surgery. If you enjoyed today's episode, please follow the podcast and share it with colleagues. Next time, we'll dive into balloon dilation of the Eustachian tube for obstructive Eustachian tube dysfunction.
I really want to thank you for the opportunity to participate in this and share all this with you. Thank you very much, Dr. Bahar.
Thank you.